now. All right, so what I'm going to be doing this evening is talking about what I consider that must-know information related to oral motor dysfunction and swallowing disorders. As I said, the information is in chapters 9 and 12 in both review and study guides. And we'll be talking about some terminology. We'll be talking about safety and precautions, and things to look out for that might indicate that a client is in distress. We'll be talking a little bit about how we work with perhaps the other team members, like the speech pathologist, if someone's on a modified diet. So those questions can come up. If, as I said, if you have them, you can unmute yourself or put a question in the chat. I won't be able to see your hands because I have limited view of the audience with the presentation being shared. Okay, so this foundational must-know content begins with some terminology. So dysphagia and dysarthria. Can someone tell me what dysphagia is? This time I'm looking in
swallowing difficulty.
difficulty swallowing. Yes, so that's swallowing problem. As opposed to dysarthria. What's dysarthria?
Difficulty speaking or articulating.
Good. So that has to do with the oral motor structures and the musculature that has to do with articulation, right? Or being able to speak. If someone has dysarthria, could they also have dysphagia? So of course the answer to that is yes, right? So someone might have one condition or the other, but both carry with them the risk of that third term, which is aspiration, right? And that's one of the more serious complications of having difficulty swallowing or being able to manage certain textures or certain consistencies of food or liquid. So we'll talk a little bit more about what kinds of diagnoses would we expect to see dysphagia with? What is it most commonly associated with?
Stroke.
With stroke, right. That's absolutely right. So a swallowing eval may, sorry about that. A swallowing eval may be done as part of an intake for someone who has had a stroke. Where do you think you might see dysarthria? Because that could also be associated with stroke, but where else? What other kinds of diagnoses might we see a dysarthria?
Did you see it with
traumatic brain injury?
TBI, okay. And somebody, Darcy was saying?
I was asking more CP, maybe?
CP, perhaps, yep. I see Parkinson's in the chat. Okay, sometimes children with Down syndrome who have low tone, poor oral motor control can also have dysarthria, right? So both conditions in some way deal with being able to have coordinated movement of the oral motor structures in order to speak, in order to feed or swallow or eat. So it's important to understand how both of them are connected. So the one thing that I always say, that I continue to say to my students and to, recent grads or students when I teach the course is understanding what the purpose of all of the oral motor structures are is very important. So you should go back and review what is the purpose of, what is the job of the lips? What is the job of the tongue? Why is it important to, when we're working on feeding, to have someone positioned so that their head and neck are not extended? Why a chin tuck? What does that do? So you can know the interventions, but understanding structurally what all of those things do and how they work together will really improve your understanding of the whole speaking and swallowing process. Okay, so what I mentioned, okay. I was looking, sorry. I'm looking for the pages in the review and study guide, so I can refer you to those. All right, so what's aspiration? It's a pretty serious thing, right?
When food gets trapped in your lungs.
Uh-huh. So what happens is you're absolutely correct, right? So what happens is when you swallow, instead of the food smoothly going down into your esophagus, it ends up in your trachea. And the trachea is a direct route to your lungs. So that can cause a blockage of the trachea, so someone could stop breathing. It also puts the individual or the client at higher risk for infection because food doesn't belong or liquids don't belong in your lungs. So it could cause complications with it could cause complications in the pulmonary system. That was what I was trying to get out. Thank you. Right. So understanding the kinds of interventions. So a direct intervention would involve actually using food or using liquids. So during mealtime, perhaps, right? I like context, right? So we would do eating or feeding during a mealtime. So here we're actually using food. We're looking at the creation of the bolus, the management of the bolus, what consistency the client is able to tolerate, how much food the client can tolerate. So you mentioned perhaps a child who has a gag reflex, or a child who has tongue protrusion, or someone who's had a cranial nerve injury and they can't manage that bolus. How much food can they tolerate? Are there certain kinds of foods or textures of foods that trigger a reflexive response? Where do we put the food on the tongue? Where does the spoon go? So really thinking about what is the stimulation there? What kind of food are we using? How quickly can the client, what's our pacing? So I don't know if any of you have had the opportunity to work with someone who's required assistance with feeding, or you've had to help feed someone, right? But, so the tendency is as soon as the person swallows, you're going back for the next spoon. So really understanding how much time someone needs to be able to manage that food. Someone who has an apraxia or someone who has a very slow pace may require additional time. So direct interventions are actually using food. Indirect interventions, we're not using food. So that doesn't mean we're using Play-Doh. What it means, we're probably doing some thinking about maybe some preparatory activities, or we're doing education, or we're working with whatever indirect interventions might be appropriate in that setting for that client, with those team members and with the client's family. So I'm going to refer you to, I'm using right now, I have the 10th edition of the review and study guide for OT. My OTA one, I apologize, is actually home. But chapter 9, there's a section, the very first section under gastrointestinal systems disorders in chapter 9 is dysphagia and swallowing disorders. And it really does a nice job of outlining those oral motor structures, and then kind of moves into, excuse me, some of the things or some of the conditions that might impact both swallowing and speaking. Right. So thinking about, as I mentioned, facial paralysis, you mentioned Parkinson's, we talked about stroke or TBI, thinking about the complications or what a child who has low tone might have with swallowing. Motor planning, right, also has an impact there. What about sensation? So if there's a sensory deficit in the oral motor cavity, would that impair someone's ability to manage food? So the answer is yes. Understanding also things like, well, what's the job of the tongue? What does your tongue do? Your tongue is really important in speaking, right? Your tongue moves different ways to articulate different sounds, different letters, right? In swallowing, its role is to create the bolus and manage the bolus. So someone with poor tongue control is going to get pocketing of food. And if they're also having trouble swallowing, that pocket of food becomes really, really dangerous. So I would direct you in this chapter when you're reviewing to look at these red flags, right? And the first red flag is about aspiration. So silent aspiration, you don't know that the person is aspirated, is really, really, really serious. The person doesn't react, but the bolus goes into the lung. So that person may have a weak cough. They may have no outward signs of aspiration, but then they get sick, or they get some kind of lung infection, or they seem like they get a cold. And then on x-ray, we see that the bolus has gone into the lung. So there could be respiratory distress there and no cough. Once a person is coughing, we at least know that they're trying to dislodge that bolus. But what happens if the bolus gets caught in the throat? Right? So if it gets caught in the throat, then we might have to be thinking about the Heimlich maneuver, right? So if somebody starts coughing or gasping and they can't breathe, then we would be thinking about the Heimlich maneuver, or CPR if they lose consciousness. So I'm looking at the chat and I see, how do people who can't swallow take medicine? Does it have to be liquid? So if you can't swallow or can't manage certain consistencies. So one of the most common things that individuals with dysphagia have difficulty managing is thin liquids. So where you usually take your pills with a glass of water, you might have to have them crushed in something, in food. You might have to take them with a thickened liquid. If you're having trouble swallowing a pill, then most often what happens is they're crushed and put into food. But I see Eric B put in IV, perhaps. That's a pretty serious case that you would have to have IV medication. Good question, though. Okay, let me think. Things that come up on the exam, you can expect that aspiration and its connection to dysphagia will be on the exam. Knowing what the safety precautions are related to someone who has a modified diet, it's your responsibility as a practitioner to know what that is, to be able to educate the client and family, reinforce that education that probably has happened from the speech pathologist or from the physician or the nurse or whatever. So we all work together as a team. And to be thinking about, what are the immediate interventions that need to be done in the event that someone is having difficulty. So I mentioned aspirations, choking. Those are the things that most commonly come up on the NBCOT exam. All right. Let me see. So this is the exam item of the week. So the patient here is having short, rapid breaths, but no cough. So this is exactly what I was talking about related to what we would call silent aspiration, right? Person's not really coughing, but they're having some respiratory problems. So this is a case where we would have to act immediately, right? And that correct response is to begin the Heimlich maneuver. Get that bolus out of there. Okay. Did anybody have difficulty with that question? Did you see it before? I don't think we've changed this particular exam item for a while. But waiting a few minutes is never an option. Giving the patient a break is pretty much like waiting a few moments, right? And monitoring something. So we're not going to monitor, we're going to act. Right? And the bolus would already be past the mouth if these symptoms are occurring. So that's why choice B is correct. It responds directly to a very dangerous situation.
Can I ask you a question?
Sure.
So how would this be if it was the answer C? You would have to, you just would tell them to open up their mouth. They wouldn't have no coughing or anything like that. That's what.
So I guess so I might ask the person to open their mouth if I suspect they're pocketing food,
Okay.
as opposed to having swallowed and it's gone down, quote unquote, the wrong way. It's gone into their lung instead of into their esophagus and their stomach. So this constellation of symptoms that's on the screen, short, rapid breaths, not coughing, it seems like it's a sudden onset. Something has gone wrong with managing that bolus.
Okay. Thank you.
You're welcome. You're welcome. Okay. So I'm going to stop my share and try not to do that. Hang on one moment. And